Welcome to Dr. Lottie's Science with Soul. I'm Dr. Lottie and the host of this podcast. Today, I am so honored and excited to have Heather Guidone with me, who is really an endometriosis expert, and you will find out why. So let me introduce her to you all. Heather Guidone is a board-certified professional advocate and the surgical program director of the Center for Endometriosis Care, CEC, where she is responsible for coordinating the comprehensive multidisciplinary care of the center's global patient base, facilitating the CEC's clinical research and surgical fellowship programs, and engaging in disease education, advocacy, legislative, and public policy endeavors. Heather has worked professionally in the endometriosis space for over 3 decades on bench to beltway to bedside efforts in education, research, policy reform, patient-centered care, and more. But most importantly, has also deeply lived the experience with stage 4 endometriosis, which informs and brings a personal perspective to her professional efforts. Heather also volunteers her time to several collaborative endeavors, serving as a board member, advisor, speaker, endometriosis grant and abstract reviewer, and member of many organizations, councils, committees, special interest, and working groups for endometriosis. She has written extensively on the disease and contributed to other books and publications on endometriosis as well. Her focus remains on reducing diagnostic delays and striving to improve access to early and effective care for all who may struggle with the disease and related gynepathologies. So welcome, Heather. I am so delighted to have you as a guest today so that you can educate the world on what endometriosis really is.
Thank you. It is a true honor to be here. I'm so excited. I love everything that you do. And I just think this is just a great opportunity for us to collaboratively and collectively educate your audience and beyond. So thank you so, so much. I really appreciate it.
So you have a whole personal story that goes along with this. You struggled with the stage 4 endometriosis. So can you just share a little bit about your own personal story and how that led you to the work that you're doing now and becoming an advocate?
I do. Absolutely. Yeah, I do. And I can, like others with the disease, I struggled with what was later proven to be stage 4 endometriosis, probably even before my first period. I can look back now and really connect those symptoms even at a very early age. And really the pain started with a lot of GI issues, later on menstrual issues, and then it just really kind of worsened from there. Ultimately, throughout my struggles with the disease, I ended up having over 20 surgeries, all of which failed, multiple medical therapies, all of which failed. And really, the disease really became such a profound part of me and my life. Just even early on in the journey, it really shaped every aspect of my whole being, my health, my emotional well-being, my physical and mental health, my relationships, my fertility, impact on career, and just really my ability to engage in my own life. And it was really not until much later into my journey that I was able to access, I was very privileged to access finally excision surgery. And that was really where the healing came in. My fertility was restored. My quality of life was restored. Unfortunately, I know that I am not alone in that story. It's, pain is the universal language. I know many people with endometriosis will relate to that and can understand that it will resonate with them because we all have a shared story. Even though it may be different for each of us, we can all recognize the disease and the impact it has in each other. The sad part is that even through our best efforts, even 3 decades later, really not that much has changed in some aspects of the time to diagnoses and really the care standards, which are still so poor for the disease. I would dare say we are possibly even going backwards in some spaces. So really, my enduring goal is not to be the voice for endometriosis or center myself, but I want to ensure that others find their voices and that they're being heard in all the places where decisions about endometriosis care and treatment are being made. So, I really use my personal perspectives to inform my professional perspectives, because I think that's the only way we're going to get done is if we do it ourselves as a community, because if we wait for the other side to fix things, they are not going to. So I join with all the advocates around the globe and both on the medical side and the advocacy, lay advocacy side, to really work together with like-minded people to try to make a difference.
Mm-hmm. So you mentioned briefly GI issues. When people don't think about the other things that happen when you have endometriosis, can you just briefly tell us what kind of GI issues people typically experience?
Yeah, absolutely. Folks really do think a lot of the time that endometriosis is a disease of periods and it only causes killer cramps, quote unquote. In fact, it really is a systemic disease. And when we talk about endometriosis, which is clinically defined as the presence of endometrial-like tissue found outside the uterus, we're not really conveying that it can be found systemically. A lot of doctors still tell their patients it's only found in the pelvis and only affects the reproductive organs, and that's just not true. It can affect your bowel, your bladder, your lungs. It can be found as far away as the brain. It can be found in the back of the knee. I mean, there are countless places where the disease has been documented in the literature. For me and many like me, I had very deep bowel disease. So you can imagine the impact of that. When we're talking bowel dysfunction, we're talking excessively severe bowel cramping pain, IBS type symptoms, and in other words, like things like diarrhea or constipation or alternating. Really, I mean, it sounds silly, but if you've lived with it, it can prevent you from leaving the house. And there were times of my life when it was ruining my life. I can handle a painful period. This is not that. Endometriosis is not simply painful periods. It's bladder dysfunction. It's adhesions sticking your uterus to your pelvic sidewall. It's a disease torsing your ovaries. It's collapsing your lung. I mean, there's so many different facets of this disease that really still aren't looked at by so many. And for me, it ended up needing a bowel resection. Had that been taken seriously sooner, if I had been believed as I was being bounced from urology to gynecology, to gastroenterology, to mental health practitioners, had I been believed and I had access to the proper surgical intervention earlier on, maybe I wouldn't have needed a portion of my bowel removed. Unfortunately, that's a sad reality for many of us with endometriosis. Since my excision, knocking wood, I'm far improved. I lived with a very severe disease for a very long time, so I can't say that I will ever be well 100%, but I can tell you that I can leave the house, I can go to work, I can show up at events, I can lecture internationally. I couldn't do those things when I was in the midst of my, most severe days with endo.
Mm-hmm. So if you were going to describe, I mean, you touched upon it a little bit already, what is endometriosis? And like you said, it's not just in the pelvis.
Right. Absolutely. There's this notion that still persists that endometriosis lesions and endometrium, the native endometrium, are identical tissue, and they are not. We know that there are a lot of histological differences between quote unquote normal endometrium versus the ectopic endometrium or the ectopic endometrium. They just don't behave the same. So the clinical proper definition, as defined by the International Endometriosis Working Group, is a disease characterized at surgery by the presence of endometrium-like epithelium and or stroma found outside the uterus. Typically, endometriosis is considered an inflammatory disease or associated with inflammatory processes. Simply put, when the lesions are located throughout the body, wherever they are, what they're really doing is resulting in a sustained inflammatory response. Things like inflammation, adhesions, fibrosis, scarring, anatomic distortion, neural infiltration, which of course can lead to a multitude of symptoms, not just pain. I mean, it's uncommon, but you can have no pain with endometriosis and have severe organ dysfunction that you weren't even aware of. So yeah, I mean, it can be found in multiple parts of the body, and it can hurt multiple parts of the body. And it has a really negative, I want to stress that, highly negative impact on daily life activities.
Yeah. And so people have, they have painful periods and they go to their gynecologist, and then they're either not believed or they're giving a birth control pill. So can a birth control pill control endometriosis?
So, there's a couple different schools of thought as far as hormonal suppression and things like GnRH analogs are concerned with endometriosis. The idea behind all of them, and one is not necessarily superior to the other, is really to sort of quote unquote quiet the inflammation, quiet the lesion. It's not treating the actual disease. It's not treating endometriosis. It's treating endometriosis associated pain. Now, for some, that's enough. And that's wonderful. That's what we want. We want relief, right? The problem is when the individual comes off any of these therapies, the disease is still there. So it's more likely than not that you're still going to have persistent symptoms. And on the other hand, some folks don't really do well with suppressive therapies, whether it be a GnRH analog or even a continuous oral contraceptive. Some people just don't tolerate them well. And then you have the other aspect of expense. Some medical therapies are very, very expensive. Some are not covered by insurance. Some folks don't have insurance. I mean, there are ways that you can access medical suppression through pharmaceutical support programs, but sometimes they make you really jump through hoops. So it's not a perfect solution by any stretch of the imagination. It can be helpful. We want patients to have all of the information so that they can make an informed and educated decision about what treatments to try. For those in whom medical suppression works, that's fantastic. Others in whom it doesn't, they deserve further intervention, whatever that looks like to them.
Yeah. And you mentioned you had 20 surgeries. Is that what you said? Over 20?
And that's really, for lack of a better term, that's really kind of criminal. And it borders on ethics, I think, but I don't blame my surgeons, the doctors that did my surgeries. I blame the system. I didn't know any better back then. They clearly didn't know any better back then, and the mindset that you want to cut the disease out is not flawed. You want to cut the disease out, but that's not what they were doing. They were simply burning it. Nobody was excising it. So every time I went in, I would have disease left behind, and then it would be buried by new fibrosis, new scar tissue, new adhesions, which of course cause their own problems. So that also, because of all of these failed surgical interventions, that also made my proper excision surgery that much more technically difficult, because at that point, then it was bowel resection, it was frozen pelvis, it was a very lengthy surgery that had to be done with multiple specialists in the room. And it shouldn't have gotten there. I should have had, like everyone should have, access to timely, proper care.
So is that common that people have a lot of surgeries before they find an excision surgeon that will actually cut out the endometriosis?
Unfortunately, that is what we see in the patient community still now, even, today. Mm-hmm. What does hearten me is that patients have become so much more empowered to take control of their own health. We have access now that we didn't have 25, 30, 35 years ago to instant information. Mm-hmm. Patients are very savvy. They're very smart. They're in charge of their own body and they know it. Mm-hmm. And that's very exciting because I know that they're not going to tolerate subpar treatments anymore. And I commend them so much for taking control of their health and well-being. And, they're going to go to one or two doctors. If they're not being treated right, they're going to find a new one. The problem we have with that is, unfortunately, the specialists are often inaccessible. I work at one of the most prestigious centers of expertise in endometriosis in the world, and we try to make as much care as we possibly can accessible, but there are 190 million people struggling with this disease, and a handful of specialists around the globe. So it's a very difficult system to navigate. And even if you have the best information and the best education, there are still barriers in the way. And that is sort of, one of my priority projects that I will continue to chip away at, as I have been. I will still continue to push that boulder uphill until everyone can get the access they deserve, because nobody should have multiple failed surgeries. I'm not saying one surgery will fix you. I would never say that. But I would say that the least amount of times that someone has to have invasive surgery, the better. I would definitely say that.
Absolutely. So how many, I've heard that, 1 in 10, have endometriosis. Would you say that's an accurate number?
We can only go by the research. The research says it's approximately 190 million individuals. That's a whole lot of people. I suspect there are people outside the scope of the research who are undiagnosed and therefore not counted or estimated. Those who do not present with sort of typical quote unquote symptoms, dyspareunia, dysmenorrhea, things like that, who are maybe having a collapsed lung from thoracic endometriosis. Maybe that's their only presentation. So I suspect it might be higher, but we can really only go by the studies that we have in the scientific literature, and they're coming in at about 190 million people.
Wow.
That's 190 million people living with, physical impact, intangible impact on daily life, activities, work presenteeism, work performance, ability to get a raise because of their performance, shortened time to be with their loved ones and their family, because their family wants to go out and do whatever and they're on the couch. I mean, that was me. I know that. We know that the disease really severely diminishes the quality of life in every aspect. Like I said, sexual, reproductive, emotional, careers, body perception, you name it. Endometriosis touches it. So it's a really costly disease affecting a whole lot of people. In fact, the recent studies that are out as of just a couple of years, they put the costs at almost 70 billion annually in just the United States. So if you extrapolate that globally, I mean, it's staggering in so many ways.
Yeah. I mean, it's mind-boggling. But when you think about all these people that have endometriosis, and it could even be more people, and how many excision surgeons do we have in the United States?
In the United States, I mean, I would hedge a bet, maybe 150, 200, maybe.
Right. Yeah, I know. And think of all those women, right? And some countries don't even have excision surgeons.
Absolutely.
And I know your clinic where you're working at the CEC, it's in Georgia, right?
Yes, and we treat internationally, and you are absolutely right. We treat internationally because there's
people fly in, right, from other countries. That's
yes,
what I've heard, to get the surgery at the CEC, because they don't even have a surgeon that can do the surgery in their country,
or anybody that believes them.
Yeah.
Terrible. It's it's a terrible situation, compounded by so many different political trappings and so many different things, differing agendas, differing politics, and differing influences. And in the middle of this tug of war is a person who just wants to live their life. Mm-hmm. And we should be throwing as much money as we can possibly get at endometriosis care and research. And we're just not. Yeah. And that's got to change.
Yeah. And can you tell us a little bit about how do you diagnose endometriosis? Because many times, people come to me and they'll say, well, I saw my gynecologist, I have these terrible periods and very painful, sometimes heavy flow. They did an ultrasound, but they said, everything was fine. There's no cyst, everything is clear. So other people will say I had an MRI, but everything was fine. So how do you diagnose endometriosis?
Well, there is definitely a growing call to action, if you will, for clinical diagnosis, which in theory, you would think would cut down on the time to treatment, but unfortunately it doesn't, because what's happening is people are being dismissed on the basis of negative imaging, which in fact is not it has not been negative. It is just due to interpretation in what they call operator dependence, or they are seeing it on imaging, and instead of being offered surgery, they're just being put on medical suppression. So that's a very tricky ground. I would dare say that surgical biopsy, histopathological analysis is still, right now today, the only accurate diagnostic measure. This is still supported in the literature. Laparoscopy allows for visualization of the lesions, but it also allows biopsy so that you can prove what it is you're taking out. And it allows for treatment at the same time, which is so important. You can have a very, very high suspicion of endometriosis based on symptoms, pelvic exams, some physical tests and lab studies. There are no non-invasive biomarkers outside the bench setting. There's really no way to look and say, well, on the basis of this pelvic exam, you absolutely have endo. It's all a matter of high suspicion. So when you're using things like imaging, they're really key to help lend towards the diagnosis. But, and certainly for pre-surgical planning, I want to add that. But we can't consider absence of evidence of absence. So if you go in surgically, there's a chance, of course, even with classic symptoms, the person may not have endometriosis, but something's causing their pain. More often than not, however, they'll get in there, the surgeon will visualize it if they know what they're looking for, take that biopsy, excise it, hopefully, and remove the disease that way. So you really want to confirm the diagnosis and allow the disease to be removed in the same encounter. And that is surgically. It's minimally invasive, laparoscopy, but it's still surgery.
Mm-hmm. So now, can you summarize? I know you touched upon it a little bit, but what are the different treatments and therapies available for endometriosis?
Yeah, so I mean, one of the things I do sort of want to clarify, I mean, you're not treating a lesion, you're treating a human being. Okay, so endometriosis is not one size fits all, and the treatments are not one size fits all. And surgery is not the only solution, it's not the only answer. Endometriosis really has a systemic body-wide effect. So it's going to need multidisciplinary and often long-term management, medical, surgical, bio, psychosocial. Typically, as the algorithm goes, the treatment algorithm, typically you're looking at surgery, often followed by medical therapy in some cases. As I said, none are curative, all have potential side effects. All are similar in clinical efficacy in terms of reduction of pain. They don't treat the disease. Endometriosis will still be there.
Mm-hmm.
But if it brings relief, that's what we're looking for. We're looking for relief. Some drugs like the GnRH analogs, Lupron, elagolix, relugolix, they can be very costly. Sometimes they're so poorly tolerated, the patient can't finish the therapy. All of them are contraindicated to fertility. So if a person is concerned about family building, that's not an option for them. But again, we want to give patients every option in the armamentarium so that they can make an empowered choice about their own care. To a lesser extent, we're looking at things like mindfulness, acupuncture, certainly pelvic floor therapy, absolutely. Diet, nutrition can be very helpful for some folks. Not that there's an endo diet per se, but what works for that individual, sort of a process of elimination they can try. Support groups are great. If you can find a good support group, there's so much to be gleaned from that. They can be very empowering. They can be very educational and informative. But certainly, yeah, I mean, there's many, many multidisciplinary components, whether it be surgery, medical, alternative therapy, pelvic floor therapy, or what is most common, a combination of all.
Yeah, so it's such this is like a big ocean for people to maneuver and try to find the care that is going to be the right care for them. And
Absolutely.
it's difficult for patients who don't even know if they have endometriosis. And then they're told that, oh, it's probably not endometriosis. And then they have, and then they finally get surgery and they have severe disease, right?
We hear a lot. You've had a hysterectomy, so you can't have endometriosis. You're postmenopausal, you can't have endometriosis. You got pregnant, so your endometriosis is cured. You're a teen or adolescent, you can't have endometriosis. None of that is true. None of that is true.
Yeah, heard it all.
Absolutely.
Right? Heard it all. And it's fascinating because here, if those teenagers that are suffering so much, missing school, trying birth control and it's not working, and they're still slipping through the cracks. And they're just told, it's in your head, or just take more ibuprofen, or
suck it up. Mm-hmm.
Yeah. And you're just, you must just be more sensitive. And it's really terrible gaslighting because
terrible gaslighting. You really are you are becoming formative during those years. And if you're constantly told that you're making it up, malingering for attention, catastrophizing at this young age, what does that do to the psyche of a person? They become older. And we know from studies, multiple studies, almost 70% of adolescents who have pelvic pain in the teen years, they're going to go on and become diagnosed with endometriosis. So this dismissal, or this notion that younger folks can't have endometriosis, it's cruel. It's not only wrong, but it's cruel.
Yeah, because they are suffering, and they're not being heard, and they're not being treated. It's unforgivable. What other disorders or diseases do we sometimes see with endometriosis?
Yeah, definitely. I like to say endometriosis doesn't come alone. It has a lot of cousins. It's not just some period disease, or it's not just solely involved with menstruation. It definitely impacts people apart from their cycle. It's definitely present among non-menstruators, whether as we talk about hysterectomy or menopause, or for whatever reason. We see things like GI issues, IBD, inflammatory bowel disease. Some folks have SIBO and things like that. Some just have a really dysfunctional bowel that hasn't had a diagnosis yet, but they know their symptoms are bad, but there's no endometriosis involvement with the bowel. So it's a secondary issue. Other gynepathologies, things like fibroids, things like adenomyosis, which in the old days used to be called endometriosis interna. It is not. They are separate diseases, similar in pain though. The difference with adenomyosis is that it's typically of uterine origin pain. It can cause excessively heavy clotting and bleeding with menses, a lot of dyspareunia, as you would see with endo. The difference also with adenomyosis, which is so common alongside endometriosis, is that a hysterectomy will cure adenomyosis because it's confined to the myometrial junction of the uterus. Certain autoimmune diseases, for example, like me, I have Hashimoto's hypothyroid. You will find a lot of folks that have similar autoimmune diseases, things you wouldn't expect, allergies, asthma, fibromyalgia, chronic fatigue. We have recent research that's indicating coronary heart disease, things like rheumatoid arthritis. And unfortunately, we know infertility as well, and pregnancy issues, things like adverse obstetrical outcomes, but also, unfortunately, malignancies, a very, very low risk, but a risk nonetheless of either malignant transformation and or a low risk to certain cancers, things like breast or ovarian cancer that we see. So it really doesn't come alone. There's pelvic floor dysfunction, there's painful bladder syndrome or interstitial cystitis, there's IBS-like types of disorders that are very, very common.
Mm-hmm. How common is it that people also develop other type of autoimmune diseases such as lupus or multiple sclerosis? does that go hand in hand with endometriosis? Are they more likely to get some other disease like that as well?
Not necessarily more likely, but we do see in the literature a higher preponderance of those things in people with endometriosis versus those in the non-endometriosis population.
Mhm.
I don't think anybody has been able to draw any conclusions specific enough to say, well, look, if you've got endometriosis, you absolutely are going to have thyroid disease. I don't think we can say that. What I think it does is it should turn on the alert to say, okay, look, I know I have endometriosis. Could I also have something else? If someone is suffering from suspected Sjogren's or RA or lupus, as you said, we should be able to incorporate that history into the patient profile so that they can go and present to their physicians more armed with knowledge and information. I am one of those people that really puts their hands up at sort of the fear mongering that surrounds endometriosis, but at the same time, we don't want to minimize this disease in any way, shape, or form either. We talk about the comorbidities not to frighten people, but so that they're aware. If you are a person with endometriosis who becomes pregnant, know that you may have an elevated risk in some circumstances of obstetrical outcomes, adverse obstetrical outcomes, things like preeclampsia, me also. We want to arm patients with education. And we want to arm providers too, so that we can best care for those patients.
Yeah, absolutely. So what are some gaps in the approach to the disease, and how can we work to fix them?
Oh gosh, how much time do we have? A week-long show? I would think the most pressing and urgent need really is to improve that time to diagnosis, really to improve the failing standards of care. We've got to get quicker, more effective care to everybody who is impacted by endometriosis, whether they are adolescent or postmenopausal, and not just those trying to conceive. I don't want to make this a disease of fertility either, just as I don't want to make it a disease of periods. People's value is not based on their procreative potential. Some folks are not interested in family building. They deserve a pain-free life as well. So while, again, it's good to be aware of the potential link to infertility, we've got to focus on treating the person and what their needs are and what their goals are. Definitely a timely need to get in there and diagnose the disease and improve those standards of care. You'll hear me, and those who follow me, you'll hear me talk a lot about the need for the formal recognition of endometriosis as a subspecialty. What I mean by that is, if heaven forbid we have a malignancy, what do? We go to oncology. When we're dealing with the bladder and the kidneys, we go to nephrology or urology. We deal with GI, we go to a gastroenterologist. When we deal with endometriosis, we go to an OBGYN who treats a gamut of things. So we need to separate, the big O from the little g, and really acknowledge and formally recognize endometriosis care as a subspecialty. And that, I think, will also help with the coding and reimbursement issues, which are a huge problem for access. Certainly the desperate need for funding. We absolutely have got to have better, more, quicker, additional funding of quality and unbiased independent research. We got to look beyond disease origins apart from the Sampson model. We've got to look at the cancer endometriosis connection, really promote and support that multidisciplinary approach, not just for pelvic pain associated with endometriosis, but for endometriosis as a whole. We really have to reduce the cost burdens to patients. And I think ultimately, if I'm given a dream list, I would love to see non-invasive diagnoses, real ones, truly useful ones. And I know we are heading in that direction, but I feel like that's so far off that it doesn't translate into any benefit for the patients of here and now. So We've really got to offer better tertiary support to those who are struggling now. And we do that by diagnosing them and treating them on a patient-centric basis in a way that meets their goals, their wishes, their outcomes, and their disease. This is not a disease that can be treated in isolation. It really is a team effort, like I said, yeah, cut the lesions out, but the story doesn't end there. A lot of times, like in my case, endometriosis was present for so long and so poorly treated that can bring harm as well. So it's not easy to fix that. And we've got to stop that. We've got to get away from that. We've got to start addressing the big picture, include those secondary pain generators, prioritize the patient's health in every aspect of their well-being, not just cutting out a lesion. No, help them get to, better specialists, PTs, alternative therapies. Like I said, of course, nutritional approaches. It's a systemic illness with body-wide consequence, and it's going to take multidisciplinary care to treat that whole person. The quicker we can get in and intervene on a patient's behalf and do that, help not just their body, but we've got to help their mind, their emotions, and their spirit, because this disease is soul destroying. There were many days when I felt like this is really godless, this disease. I don't know how to get away from this pain. And I know I'm not alone when I say that. I know there are millions of others like me out there. So I think we really need to take the first really strong, decisive steps towards better outcomes for everybody with this disease. Mm-hmm.
Now, you've touched upon some of the symptoms of endometriosis. So all the listeners out there now thinking, maybe that this is my problem. I recognize a lot of things that you've said, and maybe I have endometriosis. So what are the typical symptoms that somebody who has endometriosis would experience? Do they all have to have painful periods? Do they all have painful sex? Or is it?
No, definitely not. Those are very common. Painful sex, and not just penetrative sex. It can be pain with arousal. It can be pain with orgasm. It can be pain with penetration. It can be pain tomorrow after the event. But dyspareunia at large is definitely a hallmark. But again, not everybody has the same symptoms. Not everybody will have all symptoms. Some folks may not even know they have the disease, and it's found incidentally, which is less common. More often than not, you will hear symptomatic cases. I like to separate endometriosis from menstruation, but painful periods are part and parcel of endometriosis for many. Now, that does not mean you have killer cramps and that means you have endometriosis. There's a difference between dysmenorrhea and painful periods, painful menstruation with endometriosis. Most people with painful periods will find that they can take an over-the-counter remedy or a heating pad or all the above. They can go about their life. With endometriosis and or adenomyosis in particular, you are not able to conduct your normal activities. You're calling out of work. You're not able to attend school. You're not able to care for yourself or your family or your responsibilities. That is endometriosis related menstrual pain. Things like not being able to use or insert a tampon, things you wouldn't think of. Painful pelvic exams if you're at the OBGYN. It's not supposed to hurt. It's uncomfortable, absolutely, but it's not supposed to be crippling. When we see extra pelvic disease, things like thoracic endometriosis, you may cough up blood. You may have a collapsed lung. There's a lot of different manifestations. You may have painful bowel movements. You may have painful urination. That cannot be attributed to any other, infection or disease process like a painful bladder syndrome, although you may have painful bladder syndrome and endometriosis together. Fatigue, things that, sound like, well, yeah, we're all tired. Okay, but are you excessively tired? Nerve pain, crippling pelvic pain does not have to be associated with your periods. You may very well have pain without periods and or throughout the month at any time. So all of those different things, taken together, or I should say even taken together, doesn't mean that you have endometriosis. But if you have any of them, you might want to think about an endometriosis diagnosis. Now, particularly if you have a family history of the disease, a female relative, a mother, a sister, even a distant, a cousin or a second degree relative, you may have as high as a 7-time risk of developing endometriosis yourself, because there are genetic components. I tell patients all the time, nobody knows your body better than you. If you feel like something is wrong, something is wrong. It may not be endometriosis, but these things, endometriosis should always be considered around these things.
Mhm. So you touched upon something earlier about the GI, and people might have diarrhea or constipation. And these patients would often get misdiagnosed maybe with IBS. And so they have painful periods. And so they are told to take Motrin or ibuprofen. And then they're told they have IBS.
Mhm.
But in fact, they have endometriosis on the bowels.
Absolutely. And you raise a good point when you say on the bowel, because not everybody with bowel endometriosis needs a resection. And I do want to point that out, because I know we talked a little bit about the surgery in the bowel. You can have a small focal lesion anywhere near or around the GI tract that has not infiltrated, and it can still wreak havoc. When the disease starts infiltrating through the muscularis or penetrating organs, that's when we talk about things like resection. So I do want to caution, even if you have bowel endometriosis, it does not mean that you need a bowel resection. It can often be very safely and very successfully excised off the bowel. But yeah, I mean, a lot of times, particularly with younger patients, it's just your nerves, or, take a pill, or, like you said, take an ibuprofen, take a loperamide. If you're chronically experiencing IBS type symptoms, chances are good you've got possible endometriosis. And I say IBS type because, IBS is really indicative of an other underlying cause. In and of itself, it really isn't an explanatory diagnosis. So you don't have to accept that. You don't have to accept that, your life is just about where the next bathroom is going to be. There is help. There's definitely help.
So I heard you mentioned earlier that you could get a collapsed lung and maybe cough up blood. So endometriosis, now the way we think about it traditionally, we're told that it's just something that's in the pelvis or uterus. But now you're bringing light to the fact that you could have endometriosis on your diaphragm and it could collapse your lung. Can you have endometriosis anywhere in your body?
Absolutely. There's if you go to our Instagram, we have a graphic, Center for Endo on Instagram. We have a graphic with the, the sort of a stick figure. And we went through and we collated all the, not all certainly, but a great number of locations of endometriosis. And it started from the brain. We found cases on the eyelid. We found nasolacrimal, which is sort of up here in the nose area. We found spleen, which heretofore had never been diagnosed. The old moniker was that, well, it's been found everywhere except the spleen. Well, guess what? It's been found on the spleen, the back of the knee. Certainly all of the abdominal pelvic organs, certainly diaphragmatic and thoracic. I mean, we see at the center, Dr. Cinervo treats probably, if not the most, among the most highest numbers of thoracic endometriosis in the world. We see it every day. Really bizarre locations that you would not expect. There was a tip of the finger. I mean, really crazy places. Now, obviously, these are not your common presentations. I don't want anybody who gets, sort of a mark on their eye to run out and think, I've got endometriosis. It just really speaks to the level of wonder with endometriosis. I mean, from an academic perspective, from a surgical perspective, you kind of look at it and say, why don't we know more about this disease, centuries after it was first described? Why don't we know more? Why is it doing these things? So it really has been found. When I say everywhere, legitimately, I mean everywhere. Now, most commonly, of course, you're going to find it on the abdominal pelvic regions. You're going to find it in the thoracic cavity. But yeah, you can't rule it out of hand.
So I know that there are some people that when they have their period or their menstrual cycle, they complain of having cold symptoms. They feel like they're getting a cold. And also some people will have nosebleeds, or they'll actually bleed from the belly button. Do you have anything to add to that?
Yes. So with the belly button, that there's a couple points there. That could be what's called iatrogenic transplantation. If they've had prior surgeries anywhere near or around the umbilicus, perhaps some endometriosis has sort of been relocated to that area and it's causing bleeding, or they may just have it, without history of prior surgery. And yes, it can sort of, I'm looking at my belly button. It can sort of, sort of bleed and express substances and so forth. You've seen reports, I'm sure, in C-section scars, same sort of, mentality there. As far as the lungs and things like that, again, I do not want to send people out terrified to start Googling thoracic endometriosis. It has a very classic presentation. And then you mentioned sort of like flu-like symptoms too. I can totally relate to that. Oh my gosh, can I ever? In fact, you've reminded me just talking about it. Yeah, absolutely. You feel run down, you feel exhausted, you feel like, oh my God, my head, my nose, my eyes, almost like you're having an allergy attack or a flu. Very, very common. We see that, we hear that complaint a lot. And that may speak to, sort of the immunological dysfunction component of endometriosis.
So last question. I know we're coming up on almost an hour.
I know we could go forever, right?
So for all the people out there that have been listening to this podcast that are thinking, wow, maybe this is it. Maybe I have endometriosis and, I've just been falling through the cracks all these years. What can they do? Where do they find more information?
Well, absolutely. The first thing I want to say is that, yes, it is a huge problem that our people are falling into that crack every day. And that's why I think it's really so critical that everybody knows about endometriosis, even if they don't suffer from it personally, don't know anybody with it, or maybe they themselves just haven't been diagnosed yet. Again, we're talking about a tremendous disease burden in terms of public health costs and staggering direct healthcare costs on the patient, and also to society. But really that intangible toll, that lost productivity, loss of hope, we really have to continue challenging those cultural norms. We still talk about pelvic pain and endometriosis and menstruation as though it's somehow an individual's lot in life to suffer from these things, and that you just have to find your new normal. So it's really imperative that individuals know when, where, how, and if to seek help, and that they don't have to suffer when the symptoms first arise, because it's really vital that not just the public, but I say this all the time, our policymakers, our legislators, our researchers, hospital administrators, gynecologists, subspecialists, everybody is going to be involved in the care and education of patients. So everyone needs to know about endometriosis, and we need to do away with these taboos that somehow pain is a normal part of life and that people just have to suffer. Early intervention, so important. It can really help preserve the quality of life. It can reduce disease, morbidity, infertility, if that is a concern of yours, progressive symptoms, which is a concern of almost everybody who struggles. And we get through that by really informing the public at large. If you have the disease, remember, there is not one size that fits all. I know sometimes folks go to groups and they think, well, I'm not that sick. It's a relative experience. If this disease is interrupting your life, or you suspect this disease is interrupting your life in any way, that's all that matters. You deserve to be well, just as the next person. We can look at things like physical therapy, diet, alternative therapies. These are really good ways to try and manage symptoms on a non-invasive basis. Psychotherapy, not because it's in your head, but because there are things that we can do that validate the patient and really help them understand that their pain is real, and help them find coping tools and things like that, and give them support. It's really all about the support. Pain management can be really helpful. Legitimate pain specialists, especially those with an understanding of the disease, they can help patients ensure that they're really choosing the right path for themselves. Proper surgery. I would almost rather a patient doesn't have surgery than has the wrong surgery with the wrong doctor. Surgery in combination or alone can be very helpful. And you really need to remember that you are in charge. You are sort of the captain of that ship that is your body. And it should be a privilege for any doctor to want to help you and be your partner. Be a partner in your care and help coordinate your care through their network of colleagues. And we have to present patients with all options, not just what we prefer, but help them become educated and informed decision makers for their own situation. And I tell patients, it's not in your head. There is help. You can start with our website. We have a ton of free information there. I would hope anything you want to know about endometriosis, you go to centerforendo.com. There's some great groups out there, sort of check the Instagram folks, places like Endometriosis Summit, Endo Invisible, Endo Girls Blog, Endo Coalition. These are all really, really good groups that can help guide you towards multidisciplinary care and timely diagnosis. Of course, our center is, privileged to help anybody whenever we can. And just remember, you don't have to suffer in silence. You don't have to be isolated. You don't have to feel alone. There's a lot of resources and a lot of us out there which will help point you in the direction of the right doctors, legitimate education, just really helping you advocate for yourself, because that's really what it's about. It's about advocating for ourselves. What we allow is what continues. So we are taking back the narrative of this disease, and we're going to change it, because nobody's going to do it for us. They haven't yet. So it's time for us to stand up, and I will stand with anybody on that line.
I love it. And that is really the truth, that we have to take a stance ourselves. Anybody that's listening that think that you have endometriosis, go to their website where Heather works. It's centerforendo.com. And I will put that in the podcast notes as well. They have a wealth of information, and it's a great start to educate yourself on what this disease really is all about. So I want to thank you so much, Heather, for being a guest today and sharing all this knowledge with all the listeners.
Oh, it is my honor. It is my privilege. I can't think of anything I would rather do than work within the endometriosis community and the amazing people at my center, Dr. Sinervo, Dr. Arrington, and our team, but also the patients. They are the ones driving the changes. And it's such a privilege to be part of this community. And I applaud the work that you do. And I'm so grateful for the words you get out to the masses. And you're just helping so many people. So thank you so, so much.
Yeah, thank you so much for being a guest today.
Thank you. Take care.